Okay. So to begin, the acute leukemias lecture part one, we need to kind of go back to the difference between acute and chronic leukemias. Um, the acute leukemias are somewhat different than the chronic leukemias. The primary cell that you'll see in acute leukemias is the blast. In chronic leukemias, you see more mature cells, mature white cells, and maturing cells, right? In terms of the onset, acute leukemias happen suddenly and their onset is quick. They can be fatal, typically pretty quickly if it's left untreated. And chronic, it's more of a slower, insidious onset. Chronic leukemias don't usually happen until later in life. So maybe people that are 50, 60 in their 70s, right? So a little bit older. In acute leukemias are typically, it's not that they are not seen in older patients, they are, but they are also often seen in children and adolescents. The white count for acute leukemias could be either high or low. Okay, so you'll see that sometimes it is a very high white blood cell count. Sometimes it gets extremely, extremely low. Sometimes it's still within the normal limits. Okay. Um, but with chronic, you do expect to see the white blood cell count to be pretty high. And some of the characteristic symptoms that you start to see in someone who has an acute leukemia are bleeding because of a decrease in the platelets, fevers and infections because of the decrease in the neutrophils, and fatigue because of the anemic part of it. So the patient starts to get a lower hemoglobin count and they start to feel a little bit anemic, and so the hemoglobin starts to go down. Okay, so we'll take a look at this case. We'll start this lecture by looking at this person, all of the results here, and then as we finish our lecture, we can pretty much figure out, or kind of try to figure out, what this person has. This is a 7-year-old girl that was brought to the ER, or the ED, by her parents. The parents reported that she complained of headaches and being very tired over the last few days. Since yesterday, she developed many bruises on her leg, and then 1 hour before coming to the ED, she had a severe nosebleed. And in terms of the physical examination, the temperature was 101. She did have ecchymosis and petechiae in her legs when she arrived, and she had epistaxis. There was no splenomegaly and no hepatomegaly, which is an enlargement of the liver. So the white count's pretty high, as you can see here. The red cell's low, the hemoglobin is low, hematocrit is low as well. The red cell indices in terms of the MCV, MCH, MCHC seem to be okay for now. Maybe, the MCH may be slightly elevated. The RDW is also within limits, and the platelets are very, very low because you have 15,000, and that's extremely low. And this was the diff that was ordered on this patient. There was 2 segs, 5 lymphocytes, and about 93 blast cells. So this is what you're looking at right now. They're big cells, large cells with high NC ratio, very smooth chromatin, and you have some nucleoli in there that are prominent, and also, very visible right now. And so you can see that there's a lot more nucleus than there is cytoplasm, and the nucleus seems to be very, very smooth, the structure of it. And these are some of the questions that we'll try to answer by the end of this lecture. If we can go through everything first, and then we'll go back to these questions. So what happens in leukemias is that sometimes they are mutations that have been inherited, and there are times there are mutations that are sporadic mutations, that they are basically mutations that just arise, right? And they cause some issues. So leukemias originate from bone marrow cells, right? Because they are, the blood cell formation occurs in the bone marrow, and leukemias originate in the bone marrow. They can also be seen in the peripheral blood. They can be seen in the bone marrow and also in the peripheral blood. Lymphomas, on the other hand, are the types of blood cancers that originate in the lymph cell, in the lymph areas, right? Like the lymph nodes. So we'll cover lymphomas as well, but not right now. So right now, our focus is going to be on the leukemias that are originating in the bone marrow, and what are these mutations causing? Okay, so when you start reading about them, you'll realize that these are mutations that occur. It's sort of like a stepwise progression of the mutations in the genes that they give cells sort of like a proliferative advantage. These mutations can either make them proliferate a lot, or they could stop proliferation, right? Or it can stop the apoptosis of the cell. So these are the issues that start to occur because of these mutations. The mutations result in the transformation of normal hematopoietic stem cells or their precursors into leukemic stem cells. And so these leukemic stem cells then they proliferate, and then they sustain the leukemia. So this slide is kind of just showing us where some of those mutations can occur, right? So for CML or AML, for chronic myelogenous leukemia or acute myeloid, some of the mutations can occur at the common myeloid progenitor cell lineage. Some of the some of the AML mutations can occur at the more committed cells. Okay, for CML, it can occur at the multipotent progenitor hematopoietic stem cell. So it's very early on when these genes, these genetic disruptions can start to occur. ALL is acute lymphoblastic leukemia, and so that would only be occurring over at the lymphoid lineages, right? So mutations for ALL can occur as early as the common lymphoid progenitor cell or the more committed cells, like the T progenitor cells or the B progenitor cells. So these are just unfortunate events that happen that lead to these, reactions. And then these mutations sustain the leukemia throughout, okay? And there's different types. Of leukemias. And, again, they could also be chronic or acute. So with acute, what acute means is that there is rapid proliferation in the bone marrow of cells. So you could have an instance where there is an acute lymphoid, right? Like ALL, or acute myeloid, like AML. Okay. So acute, it's rapid. Okay. So anytime you think of an acute, it's happening quick. All right. So there are mutations that are causing rapid proliferations of either lymphoid or myeloid progenitor cells. So this could be causing the rapid proliferation of lymphoblasts or myeloblasts. When the proliferation of these cells, of the blasts, right, overwhelms the bone marrow, the blasts are then starting to get seen in the peripheral blood. And then the patient's symptoms start to reflect the suppression of normal hematopoiesis. They start to have cytopenias. So basically, when you start to see that the patient's having, fatigue, well, yeah, the bone marrow is being affected by all of these leukemic cells. So it's affecting the performance, and it's affecting the production of red cells, which carry hemoglobin, which takes it all over the body, right? So then there's fatigue. Then you have, the inability to make more platelets, right? So then the decrease in platelets, or the inability for the platelets to function, that can lead to bleeding, some of the bleeding symptoms. So the petechiae, the ecchymosis, and all of that, it's because of the platelet. And this is all coming because it is affecting the bone marrow. The cells are overwhelming the bone marrow. All right. So the predominant cell in acute leukemias will be a blast. All right. So it's either a myeloid blast or a myeloblast or a lymphoid blast or a lymphoblast. Okay. So, we don't know. We'll define them today because I'm going to talk about ALL and AMLs. But in terms of you looking at your diffs and looking at blasts, you're not going to say, oh, well, this is an acute myeloid, right? Unless you have that information already. And even then, it's probably not, advisable for you to say it because we don't know. There's some cases that it can go from a chronic to an acute, right? And so it changes. It can change depending on the genetic, on the genome makeup of the person. So anyway, so the blast is the main cell here. And what happens in acute leukemias, oftentimes what happens is that the genetic abnormality leads to a maturation arrest. So there is at some point kind of like a stop in maturation happening. All right. There is also increased proliferation. So either one of them depends on the type of mutation, on the type of leukemia. It's happening in the bone marrow. The bone marrow is usually hypercellular, okay? And we have two different criteria that we use to identify the type of leukemia that we're looking at. The older definition was called the French American British classification scheme. And that was it was older. It's older now because it has been pretty much replaced by the WHO, the World Health Organization. They have their own classification scheme for for conditions, for hematologic conditions, and one of them being acute leukemias. And so the criteria when the FAB used to be used, it was if they found 30% or more blasts in the bone marrow, then it would be considered to be a leukemia, an acute leukemia, right? But now with WHO, there is the consensus that you need to find 20% or more blasts in the bone marrow, and the recurrent genetic abnormality. So basically, we're not just relying on how many blasts are there to define it. It's like what is the genetic marker that you have found that will help you classify this leukemia. And so in hematology, in the world of hematology, everything gets classified, and it's very important to classify leukemias based on their count, on the blast count, and also based on the genetics, because this is how the physician, the oncologist, will approach the patient and say, all right, we know you have this type of leukemia, and these are the markers that we found in terms of the genetic markers. Some of these genetic markers that they find are going to be really good markers, and some of them are not going to be very good in terms of the leukemia, right? Because, I mean, it's bad news that somebody gets a leukemia, but within the bad news, right, the patients can still find, well, I have kind of like the best type of leukemia that I can get, right? In terms of how long the patient will live, or the treatment options for that patient, right? Or you could be on the other side, where on the other side of the spectrum, where you got the worst kind of leukemia that you can possibly get, right? And the way that we know that is by looking at the genetic markers, because they tell us, we know based on statistics and studies, what are the markers that have favorable prognosis and what are the markers that have unfavorable. That's why hematology now has become a place where we're not just looking at the cells and identifying, but also there's a lot of genetic markers and cytogenetics that come into place, that can help us identify these deficiencies, these genetic markers, because of the outcome. Because we can tell the patients, these is the outcome, this is how you're going to be treated, and this is how long you have, these these are important things that people want to know when they get diagnosed with these conditions. So acute leukemias, as I said, onset, sudden onset of it, blast is the primary cell. There is bleeding, fatigue, and lots of fevers and infections because of the neutrophilic count. So the white count, the neutropenia can occur as well, and that can lead to an increase in infections and fever because of the decreased white blood cell count. All right. So the cells are like this. We don't know when we're looking at the blasts, we don't know. These are actually blasts in peripheral blood. You would also be seeing some blasts in the bone marrow. If you're seeing it in the peripheral blood, you're probably going to see them in the bone marrow, right? But they're large cells, high NC ratio, very smooth chromatin, very prominent nucleoli. I think everyone here is pretty familiar with the blast, which I'm very, very happy about. So then let's break them up. We're going to do the acute lymphoblastic leukemias first, and then we'll talk about the acute myeloid leukemias. And so the good part about these leukemias, I don't if you can find something good about them, is that there are 95% of children, it's probably a little higher now, that get an ALL achieve remission. So through chemo or radiation or some sort of therapy that is intended for that patient, they can achieve remission, which means there's no more cancer cells, right? And about 80% of them will actually achieve a cure. So that's actually pretty good for, pretty good statistics for a type of kind of like a childhood leukemia, because it's more of a success story in children than it is in adults. So acute lymphoblastic leukemia, the predominant cell is the lymphoblast, but you don't have to worry about calling it a lymphoblast. You worry about calling it a blast, okay? Now, when you get more seasoned in the lab, trust me, you're going to be like, oh, that's a lymphoblast, because you're going to be able to tell. But right now, you're not expected to know that, okay? Acute lymphoblastic leukemia is primarily a disease of childhood and adolescence, but it can occur at any age as well. So adults with acute lymphoblastic leukemia usually get it after they're about 50 years of age. One would see that the patients experience anemia, thrombocytopenia, and a white blood cell count that can be variable. About 50% of patients with ALL have leukocytosis. So not everybody will get an increase in the white blood cell count. With this type of leukemia, there is central nervous system involvement. So it involves the central nervous system. There is a reason why, and that's because the leukemic cells in the bone marrow get so overwhelming that they can start to infiltrate the spinal cord, okay, and also other organs, okay. They can infiltrate the spleen, the liver, the lymph nodes, the testes, the ovaries, okay. They can cause what's called a mediastinal mass, all right. And both the FAB and the WHO, they both have different classification criteria for ALL. And as we know, with the FAB, which is now the older classification scheme, you needed to have 30 blasts or more in the bone marrow. Plus, they're not just looking at the count. Obviously, they're looking at the morphology. They're looking at, they used to base the classification too on cytochemical stains and the way that the cells stain with certain stains. But it's very difficult to do that nowadays. It's time consuming. And so now that we have these molecular tests and we have cytogenetic tests available, it's just easier to go for the mutations, right? And so the WHO says, okay, well, if there are 20% blasts in the bone marrow, plus there's all these recurrent genetic abnormalities, we can classify this as an acute leukemia. So these are examples of the blasts that you would see. So the thing with lymphoblasts is that there's two different types. Mainly, the most common type is seen in small lymphoblasts, which is about 1 to 2.5 the size of a normal lymphocyte. And then you have the second type, which is a lymphoblast that is a little larger. And larger lymphocytes can be about 2 to 3 times the size of a lymphocyte. So over here is more of a larger lymphoblast, and these are more of a smaller lymphoblast. It's hard because some of these start to look like reactive lymphocytes too, and so it can be it can be hard to distinguish, right? But there's two types. So when you're looking at a slide that has blasts and you think it's lymphoblastic, don't just think of the smaller ones that look like limbs, right? Those are it. No, it's not, because there's also the larger type that look more like reactive lymphocytes, and they can get very, very confusing. And so that's just something to keep in mind when you're looking at cells. It's not, you don't just have one option here. You could be looking at two types of blasts. Next is the testing that we would do. So if you find blasts in a patient and you're like, okay, obviously our prompt in the lab is going to be to do the diff, and then it won't even let you move on unless you go for pathologic review. But it's still very important for you to know what happens after, right? So when you suspect that an acute leukemia is happening, it's important to go to the source, and the source would be the bone marrow. The bone marrow, if we think it's a leukemic process happening, the bone marrow will give us a pretty good clue, right? So we can assess the bone marrow. And we talked about this already. How do you assess the bone marrow? Well, you need a sample, right? So you may or may not be able to assist in getting that sample, but you have to get a sample of the bone marrow, and then we have to stain that, and we have to do morphology on it. We have to look at the cellularity of the bone marrow. So what's the cellularity versus the fat cells, the adipose cells in there? You've got to look at many different things. The bone marrow sample can also be used not just for the morphologic analysis, but also for other testing as well. So we move on by doing a bone marrow sample, right? You're going to do what you need to do on the bone marrow. So an assessment of the cellularity. You will very likely do another differential on that bone marrow. And then you can move on by doing flow cytometry. So the actual test, the method that you're employing by doing flow is called immunophenotyping. Immunophenotyping by flow cytometry, okay? So we're phenotyping the CD markers that are on the cells just to verify and to confirm the lineage, right, of those cells, of the population that we're concerned with, right? So if we have about 70% blast cells, and I don't really know where this is originating from, all I know is that these are blasts. And I also see it in the bone marrow. There's lots of blasts in the bone marrow. Well, the only way for us to know would be by running the flow. And flow cytometry is a very specific technique. It attaches these monoclonal antibodies, and these monoclonal antibodies have fluorescent colors. And so it gives off different colors. So we can use that basis to identify and to gate our cell population in interest. So flow cytometry is like a whole nother class. I do have the lecture on flow in the media lab, which I really, really encourage you to do it, so that you can understand, because it's a very important test in hematology. We cannot move on in hematology without understanding flow cytometry, okay? Well, and also cytogenetics and molecular. But anyway, so in ALL, the steps that we are going to take is, we need a bone marrow analysis. We need to take this for flow. We need to do the CD markers to identify the lineage. Possibly the place that you're in may or may not have cytogenetic testing. So if it doesn't, it can go for send out. But if it does, it may have some of the smaller scale tests. So in cytogenetics is the study of the chromosomes. And so it's essential because cytogenetic abnormalities are seen in a lot of acute leukemias. And so it would help us identify what is going on with the chromosomes that is causing this. Okay, so we know that cytogenetic testing is essential in the diagnosis of acute lymphoblastic leukemia because there's a lot of cytogenetic abnormalities that are seen in the majority of B cell and T cell acute lymphoblastic leukemias. Molecular tests are also very important. There is molecular tests that we can use for the diagnosis, the confirmation, right? Or also the prognosis and the monitoring of the disease. We can use FISH for the detection of translocations. We can also use RT-PCR, reverse transcriptase PCR, to detect the mRNA transcripts. Mostly the mRNA transcripts, we want to detect that for what's called MRD, or minimal residual disease. And minimal residual disease is the monitoring of the leukemias. We can also do molecular testing for clonality of the cells using PCR or Southern blot techniques. So there are many different forms of ALL. There's the B cell ALL and the T cell ALL, right? Because lymphocytes are B cells or T cells, right? And so this slide shows us the different subtypes of ALL that have been identified by immunologic methods. So by that, what I mean is they've been placed in these categories based on the CD markers that they have. Remember what CD markers are? Cluster of differentiation, and this is what sets the cell apart from the other cell. It's kind of like their tag, right? What is their tag? And it really tells us about the stage that the cell is in and the lineage that the cell is at. Like, what lineage does it belong to? Is it a B cell? Is it a T cell? Is it a myeloid cell? Is it an erythrocyte? Is it a megakaryocyte? So because early cells are so difficult to distinguish, early cells, they all look the same. So it's hard. We have to do this. So based on their immunological characteristics, okay, you have acute lymphoblastic leukemias that belong to pro-B ALL or pre-B ALL, intermediate pre-B ALL or common ALL, pre-B ALL. Oh, 1 second. Okay, sorry about that. So the subtypes are pro-BALL or pre-BALL, intermediate pre-BALL or common ALL, pre-BALL, or these are the B cell ones. Then you have the pro-TALL, pre-TALL, cortical TALL, or medullary TALL. So let me explain this just a little bit because I do want you to understand this part. Pro-B ALL or pre-B ALL are the most immature types of B cells. that we need to recognize, and they are always positive because remember, stem cells are positive for CD34. Okay, so they have those characteristics because they're very early cells, right? So CD34 is a nice characteristic of a stem cell, all right? But then you'll see that when the cell starts to mature, right, and then you're getting into the more mature stages, like an intermediate pre-B ALL or a common ALL, then it starts to disappear. So it's kind of like, we could either have the CD34 or not, right? So it's a plus or minus CD34. But then if the cell gets more mature, the CD34 starts to completely disappear. So it's negative for CD34, but then it's positive for others, other markers. And so it's nice to know this, and not that I want to give you more to like remember and memorize, but these are little clues for you because it will help you tell what stage we think we're looking at, like kind of gauge what stage we're looking at. So a pro-B ALL or pre-B ALL will give you a positive for CD34, 22, 79, 19, okay, which is a very good marker of B cells, okay? HLA-DR, TDT, okay, and negative for CD10 and 20. Now, as that B cell starts to mature, we have a positive for CD 10, 22, 79, 20. And 20 is kind of plus or minus, so it's variable. But then you still have that TDT, CD19, HLA-DR. And for pre-B ALL, you're positive for, these cells start to become negative for CD34, but positive for cytoplasmic IgG, CD22, 20, 79, 19, HLA-DR, TDT, and then variable for CD10. So the whole point is, why do we need to know this? Is because some of these more prominent in certain type of population and then not in others, right? So in terms of the percentage of ALL cases, a pro-B ALL or pre-B ALL is seen in about 5% of children and about 11% in adults. An intermediate pre-B ALL or common ALL is seen in about 65% of children and 50% of adults. And this type really carries the best prognosis. So out of all of the bad leukemias that you could possibly get, someone's getting the best type, right? So it's like, oh, there's a good prognosis. There's something we can do about this one because of the way that this leukemia progresses. Okay, there is a way to stop it or a way to attack it or halt it. You know, there's just different methods. But this one is the one that gives the best prognosis. And then with the pro-T ALLs, that's hardly ever seen in children, but mostly in adults. And if you take a look at this, the CD markers that are positive here, a little bit of the lower numbers, right? So do you remember CD4, CD8, right? Those are some markers of T cells, all right? So always keep the lower numbers in mind when you're looking at T cells. And so pro-T ALL, positive for CD3, 7, 34 is variable, but negative for CD1A, 2, CD4, and CD8. As these mature, right, you have the cortical T ALLs, negative for CD34, which is something that you should always notice, but the cortical cells are CD4 and 8 double positive, okay? So double positive for CD4 and CD8 means that all the cells are slightly immature, but when they go to the medulla of a lymph node, they will either be CD4 or CD8, as you can see here in the next stage. Medulla or medullary T ALL will have either CD4 or CD8 because that's where they mature. That's what they get, their mature markers. All right, so again, you know, just to give us some information about the type of cell, the kind of prognosis. But with ALLs, okay, the WHO also takes the immunological factors into consideration. Of course it does, right? But it's also very it relies heavily on the recurrent genetic abnormalities that are just, you know, they're found and they go with these leukemias. So the category for these ALLs is called the B lymphoblastic, for B cell ALL, B lymphoblastic leukemia lymphomas with recurrent genetic abnormalities. And there are 7 types that have been identified by the World Health Organization. The first type is a very, very, very dangerous type. It has a very high risk associated with it. And it is the B lymphoblastic leukemia lymphoma with translocation 922. Okay, so when you see the T, that means translocation. 922 means what are the chromosomes implicated. So this translocation implicates chromosome 9 and chromosome 22. And then you have the area of the chromosomes that is implicated, right? So Q34, Q11.2. Now, I'm not going to make you memorize these, but the translocation numbers and the fusion genes are very important, okay? So with B lymphoblastic leukemia lymphoma, according to the WHO, the one with translocation 922 BCR-ABL1 fusion gene, okay, is a very high risk mutation. And so these happen in about 25% of adult cases and in about 2 to 4% childhood cases. So out of the leukemias that you can get, you don't want to get this type because this is a high risk type. There's the translocation V11Q23 with the MLL rearranged fusion gene. That's another one that is common in very, very young infants, but it has a very high risk. There's the translocation 1221 with the TEL AML1 fusion gene. This is the best type that you can get if it was recognized as an acute lymphoblastic leukemia, because it has really good prognosis and about 90% cure rate, and it happens in about 25% of childhood cases. Then you have these leukemias that occur with not translocations, but with kind of like additional chromosome abnormalities or less than, right, the typical number chromosome abnormalities. So you have B lymphoblastic leukemia lymphoma with hyperdiploidy, and that means that there's more than 50 chromosomes involved. That one has standard risk. And there's B lymphoblastic leukemia lymphoma with hypodiploidy, which is less than 46 chromosomes, which is very, very high risk. There's the translocation 514, very rare. Translocation 119, very high risk, okay? There is a category called the B lymphoblastic leukemia lymphoma, not otherwise specified. And so this could be very risky. No, not risky, I'm sorry. These are the leukemias that go into the category because they don't have a found genetic abnormality. So they're placed under this sort of umbrella. And then you have the T lymphoblastic leukemia lymphoma. So the World Health Organization will separate B cell and then T cell, right? So it's B lymphoblastic leukemia lymphoma, and then the T lymphoblastic leukemia lymphomas, and then it has they have their own categories of genetic abnormalities. All right. So with acute leukemias, it's important to understand some of the mechanisms that are occurring in the genetics, in the genetic abnormalities, because some of them are like repetitive. So one type will have the same, almost kind of like the same genetic abnormality as the other type, and that's because of the types of genes that these mutations are targeting, right? The genes could be genes like tumor suppressor genes, or transcription genes, transcription factors. So it's attacking things that we need, and it's occurring right at the stem cell or the progenitor cell. And so they can be seen across many different types of leukemias. So for acute lymphoblastic leukemias, that requires multiple genetic mutations for disease expression. And basically, the clinical outcome is very different in acute lymphoblastic leukemia, depending on the chromosome abnormality, right? Also, in acute lymphoblastic leukemia, we look at the chromosomal abnormality and if there are any other mutations present as well. Okay. In acute for ALL, about 25% of childhood ALL cases show the translocation 1221 ETV6 RUNX1 translocation, which is the one that we're looking at right now. And so because it's so implicated, we have to explain it, we have to talk about it. So the RUNX1, or this is the RUNX1, or it's also known as the AML1. It's a transcription factor. Okay, so this transcription factor regulates the transcription of the Hox family of genes. So the Hox family of genes basically induces transcription of target genes that regulate cell renewal, they regulate proliferation, they regulate differentiation of hematopoietic stem cells. So RUNX1 in this particular case is a transcription activator, okay, or AML1, RUNX1. It's the same thing. It's a transcription activator of the Hox genes that it's needed for normal hematopoiesis. And it codes for the core binding factor alpha, and it forms a heterodimer with the core binding factor beta, which is what you're seeing right here. So it kind of forms like a nice dimer in there. This complex, okay, binds to regulatory elements of the genes that are essential for hematopoiesis, okay, and so which are the Hox family genes. And then once it binds, the RUNX1 or the AML1 and the CBFB complex recruits other transcriptional proteins to the complex, and that includes the HATs, okay? So those are the histone acetyltransferases, the HAT proteins. I call them the HAT proteins, okay? So the HAT proteins, basically what they do is they open up the chromatin so that transcription of the Hox and other genes essential for hematopoiesis can occur. So think of the RUNX1 and the AML1 as the transcription activator. So it's going to open up the way of it's a way in which we can move on with transcription of target genes. So if we didn't have transcription of these target genes, we can't have hematopoiesis occur. We can't produce blood, okay? So it's very important that this process here occurs and that all of these genes are intact, okay? So with that said, when we have an ALL, and we have an ALL that was caused by the translocation 1221, okay, which means we've taken a piece of DNA out of chromosome 12, and there's a piece of DNA out of chromosome 21, okay, and these two came together, okay, and it led to the fusion gene, okay, the fusion of these two pieces on those two chromosomes. It's causing the fusion of a gene, okay. So it's the ETV6 RUNX1 fusion, which then converts the RUNX1 from a transcription activator to a transcription repressor, okay? And it codes for the ETV6 RUNX1 fusion protein. This fusion gene then forms the heterodimer with the CBFB, the abnormal transcription factor complex, binds to the same regulatory elements as the RUNX1, and the genes essential for hematopoiesis. And then the complex recruits for transcription core repressors, including HDACs, histone deacetylases, which close the chromatin and prevent transcription of the host genes instead of opening up the chromatin. So basically, this is functioning as a repressor of transcription rather than an activator of transcription. That's the mechanism of the gene, of that fusion of the gene that just happened, right? So in the introductory lecture, we talked about two things. We talked about two mechanisms in which genetic abnormalities occur in leukemias, right? There's the two main mechanisms are the gain of function mutations and the loss of function. The gain of function mutations, there's two different types. There's the qualitative, which is structural differences, and there's the quantitative, which is the number, right? So with the gain of function mutations, the most common type of abnormality that occurs are the translocations, and the translocation almost always leads to a fusion gene, an abnormal fusion gene, which is going to code for something that is abnormal, okay? Then the other one is the other type of gain of function mutation is where the gene gets placed, okay? Where the oncogene gets placed, okay? It leads to the overexpression of that protein. So there's two different things happening that can potentially happen, okay? So here what's happening is that we're dealing with a balanced translocation that occurred between chromosome 12 and 21, and it led to the fusion gene ETV6 and RUNX1 fusion gene right here, okay? And this fusion gene, that it's forming a heterodimer with core binding factor beta, and the abnormal transcription factor complex then binds to those same regulatory elements as the normal RUNX1 was bound to. And the complex will then recruit transcription core repressors, which instead of opening the chromatin, it closes the chromatin, so it represses transcription. So what happens when transcription gets repressed? Well, there's no more proliferation, right? There's no maturation, right? There's kind of like a stop, right? And so you see lots of immature cells because of this genetic abnormality that's occurring in the cells. So with ALL, ALL has a lot of like little different parts to it, for sure, right? And, you know, we look at the immunologic, we look at the recurrent genetic abnormalities, but also when it comes to the prognosis of it, there's other factors that you want to consider as well. The age of the patient, the white count, the immunophenotype, which is what we discussed, the number of chromosomes implicated, right? So the ploidy, the genetic abnormality, which is what we just talked about, whether there is involvement of the central nervous system too. And so whether the cells are infiltrating the spinal cord, right? The spinal fluid, and minimal residual disease, which is the monitoring of the cancer cells. So the prognosis in ALL cases will vary depending on all of these different types of factors, like the age, right? So better prognosis is seen in, or lower risk is seen in people that get it when they are between 1 and 9 years old, when the count is less than 50, when the immunophenotype leads to pre-B cell ALL, when the ploidy number is over 50, when the genetic alteration is translocation 1221 with the ETV6 RUNX1 fusion gene, right? When there is basically no CNS involvement, no blasts in the spinal cord. And so those are things that when put together, when assessed, they would put the patient in a different category, in a lower risk, lower standard, or standard risk category, as opposed to a poor prognosis or high risk category. right? So those are very important. So we look at these factors. We also look at the prognostic factors for children, most specifically. For children, children can be put in these different risk categories based on their mutations, right? So basically, they are in the low risk category if they have simultaneous trisomies or 3 copies of chromosome 4, 10, 17, and translocation 1221 ETV6 RUNX fusion gene. The therapy that's usually done for these patients is less intensive anti-metabolite based chemotherapy. Then you have the intermediate risk, you have the high risk, the very, very high risk. And as we said before, ALL with translocation 922 BCR-ABL1 fusion is not a good ALL to get, right? One would need an allogenic bone marrow transplant for therapy because it is difficult to maintain. Probably it's more aggressive, so it probably won't be managed just with chemotherapy, right? Even if it's, multi-agent chemotherapy, it won't be, that won't be enough for this type of ALL. So I hope that you understand a little bit about what is important to remember about ALL. And then I'll talk about AML, which is basically, we're just a different lineage, but it's basically the same. So do you have any questions? I just want to make sure that there are no questions so far before I move on. Okay. Let me pause the recording for a second. Okay. So let's now talk about acute myeloid leukemia. So now these are leukemias of the myeloid lineage. Acute myeloid leukemias, it's actually the most common type of leukemias in adult. The median age of diagnosis is about 67, but it can also occur at any age. The white count can be variable here. So you can see someone with AML that has a low white count, a very high white count, or a normal white blood cell count. You can range from 1 all the way to 200,000. There's anemia, neutropenia, thrombocytopenia, DIC becomes a complication of AML. Also, tumor lysis syndrome, it's a complication of AML. And so in tumor lysis syndrome, it's a combination of metabolic basically complications that occur in a patient that has malignancies. And this is caused by the breakdown products of dying cancer cells. And because of tumor lysis syndrome, that can lead to other things. So there's the probability of getting hyperkalemia, which is increased potassium, hyperuricemia, which is increased uric acid, hyperphosphatemia, increased phosphorus, and also hypocalcemia, which is decreased calcium. So this table right here shows you the AML classification that was designated by the French American British classification scheme. This is obviously now the outdated classification scheme, but as you can see, it kind of listed them as, M0 all the way to M7. And it really just took into consideration the morphology. It was very heavily relied on the morphology of the cells that were found, and how mature they were. It also looked at the cytochemical stains, so certain cytochemical stains and how it reacted, and a little bit of immunophenotyping, so a little bit of the CD markers, but not so much. But again, because now there are so many tests that we can do to assess genetic abnormalities, it's kind of like a more accurate way to tell us what kind of leukemia we're looking at, instead of kind of placing it in a category just based on what it looked like, right? So this is more specific now. The WHO classifies them specifically based on their recurrent genetic abnormalities. And so with AML, there are 8 categories that were put forward by the World Health Organization. I'm sorry. 1, 2, 3, 4, 5, 6, 7, 8. Yeah, 8 categories. Okay. So the first category is the acute myeloid leukemia with recurrent genetic abnormalities. And that category is further divided. So we'll look at that. But the main 8, so there's acute myeloid with recurrent genetic abnormalities, acute myeloid with myelodysplasia-related changes, therapy-related myeloid neoplasms, acute myeloid not otherwise specified. So not otherwise specified is the one that any kind of leukemia in which they don't find genetic abnormalities will be placed in that category. There's myeloid sarcoma, myeloid proliferations related to Down syndrome. There's blastic plasmacytoid dendritic cell neoplasm, acute leukemias of ambiguous lineage. It's the last one. So with AML with recurrent genetic abnormalities, there's 7 subtypes. So these are the ones that kind of correspond to the AMLs of the FAB, the French American British. So these sort of go hand in hand with these right here, right? Kind of. So the WHO was basically like, all right, well, we can't just base our classification on what they look like, right? On the granules and the morphology and a little bit of immunophenotyping. We need more concrete evidence. And also the genetic abnormalities gives you an idea of the progression of the disease, right? So, and also will give an idea of the prognosis for that patient. And so the first type is AML with translocation 821 with the RUNX1, RUNX1T1 fusion gene. So the ones with the red asterisk are generally favorable. So they have good prognosis, and the ones with the blue are not, okay? So we know that if we find these genetic abnormalities, then we're not probably facing the same treatment options. You know, for instance, the oncologists might want to go with something a little bit more aggressive when they find these types of leukemias. So you have AML with inversion 16 or translocation 1616 with the CBFB, the core binding factor beta, and YH11 fusion gene. You have APL with translocation 1517 with the PML RARI fusion gene, AML with 911 with the MML 3T MML fusion gene. You have translocation 69 with the DEKNUP214 fusion gene, and then all the other ones here. Okay, so let's talk about some examples. So the RUNX1 T1 fusion gene that's caused by translocation 821. In this type of leukemia, you would see lots of myeloblasts. They have some granules in the cytoplasm and some degree of maturation, as you can see here. In the AML with inversion 16 or the translocation 1616, you start to see some myeloid and also some monocytic lineages in there, also some eosinophilic cells. You have the APL with translocation 1517 PML RIRI. So this one is important to kind of like stop and explain further in hematology. This is the one that APL stands for acute promyelocytic leukemia. And so the cells are typically, the ones that you would see are typically the typical promyelocytes, right? So big cells, high NC ratio, a little bit of nucleoli may be present. But you have those primary granules that are usually all over the cell. So that's really the most common cell that you would see in an APL. However, APL also has an uncommon form, which is the microgranular variant, and they look kind of like little butterflies. They're like bilobed cells. They look like blasts because they don't have they're very smooth, right? But they don't have any granules. They don't have a lot. So that's why it's called the hypogranular or the microgranular variant. But also these are very confusing because they don't look like pros. And so, not having those promyelocyte characteristics can be very confusing when you're first looking at them, right? So this one on the, in slide A is the most common hypergranular variant, which is what you would normally see. But you have to also be aware that you may not see those granules and you may still be looking at promyelocytes, which is kind of scary, but it's important to pay attention when you're doing this, the screenings, when you're doing DIPs. And oftentimes too, because an APL is sort of like, it's still a myeloid leukemia, okay? You would see hour rods too. You may or may not see some hour rods in these promyelocytes. So hour rods are these little skinny red needles, right, that you see in the cytoplasm and near the periphery of the myeloid cell. But the good thing is when you see hour rods, you're not looking at a lymphoblast or a lymphoid cell, because those are they don't usually have hour rods, so you don't have to worry that it's a lymphoid, but it's a myeloid issue that you're dealing with. So promyelocyte would have some hour rods as well. Okay, so with acute myeloid, okay, there is with the WHO, there's let me go back. With the WHO, there's the not otherwise specified category, as I said before. There's the acute myeloid leukemia, not otherwise specified category. And so typically, because there's no genetic abnormality that is found, they usually will place these individuals that have an acute myeloid into this category, because there's no genetic abnormality that is really coming up for those patients. And so that in that case, they could be classified using the corresponding FAB classification, right? So AML with minimal differentiation would be an MO. AML without maturation would be an M1. AML with maturation would be an M2. Acute myelomono leukemia would be an M4. Acute monoblastic monocytic leukemia would be an M5. Acute erythroid leukemia would be an M6. Acute megakaryocytic leukemia would be an M7. Okay, there's also an acute basophilic leukemia, and the acute panmyelosis with myelofibrosis type of leukemia. But for these, the blast count has to be at least 20% in the bone marrow, or in the peripheral blood, and that's required for diagnosis. And the acute myeloid leukemias, not otherwise specified, account for about 25% of the AMLs. So it's like they happen, or there's people that there's no genetic abnormality that is recognized, and we can put them under this category, and we can classify them based on what we see on the cells, on some of the immunophenotyping as well. Okay, these are the leukemias that just don't fall easily under the specified categories that have been delineated by the WHO. Okay, so just some examples of M0. M0 has acute myeloid with minimally differentiated, so a lot of blast in here. There's N1, acute myeloid without maturation, so slightly more mature. There's the M2, which is acute myeloid leukemia with some maturation. This one, there's less than 10% maturation that goes beyond the promyelocytic stage. You have N4, which is acute myelomono, which is like a combination of myeloid and monoblasts, mono cells. Then you have acute monoblastic leukemia. So these are like the monoblasts in here. Okay. So for M4, you have both myelocytic cells and monocytic cells. For M5, you have more than 80% of the cells in the bone marrow are monocytic. Then you have M6, M7. M6 is acute erythroid, and this has erythroid precursors showing dysplastic features. So these are sort of like the NRBCs, if you take a look at that. And then the M7 is the acute megakaryoblast leukemia. And this picture has megakaryoblast. And they vary in size because some of them are not that big. But, you know, for example, this one could be, looks like the size of a lymph, right? And then this one looks like three times the size of a lymph. So, you know, it's hard to know what they are because they look sometimes they look very dysplastic, but that's why flow is so helpful in here. So just to explain some of the common AMLs that you may see, a common one involves the translocation 821 in the RU1X1, RU1XT1. And so it's important to know, well, this one in particular, the 821 with the RU1X1, RU1XT1 translocation only happens in about 5% of AML cases, right? But the core binding factor, it gets implicated in a lot of these reactions. It's involved in the activation of about 50 genes that are involved in hematopoiesis. All right. So AML with these translocations, the 821 RU1X1, RU1XT1 fusion gene has myeloblasts with some dysplastic granular cytoplasm. You'll see some aurarods. You'll see a little bit of maturation. So that's similar to the AML M2 designated by the French American British. So let's just take it back a little bit and remember the core binding factor. Remember that core binding factor is involved in the activation of more than 50 genes that are involved in the in hematopoiesis. RU1X1 or AML1 binds to core binding factor and forms a heterodimer, and this heterodimer then binds to the HAP proteins and opens up the chromosomes, and it allows the transcription of the HOX genes, which are necessary for hematopoiesis, right? So when there is that translocation that occurs in AML, the translocation between chromosome 8 and chromosome 21, it's called translocation 821. A piece of chromosome 8 comes out and a piece of chromosome 21 come out, and they form a fusion gene together. The gene that results, the fusion protein, it's the gene is the RU1X1-RU1XT1 gene, and that gene prevents transcription of genes needed for maturation, resulting in a maturation arrest at the blast stage. Okay, so instead of activating transcription, it's repressing transcription of our target of our genes that target for transcription in hematopoietic cells. So what is happening is at that stage, it's stopping it. So it's not going to allow more maturation, okay? So there is sort of like a arrest in maturation that occurs because of this translocation. So what you're seeing is the same type of cell, the same time, which is usually an immature, kind of like a blast stage, okay? So let me explain this here, which is the molecular pathophysiology of M3, which is the acute promyelocytic leukemia. Okay, so acute promyelocytic leukemia occurs due to the translocation, what is it called? 1517. okay? And the diffusion gene in acute promyelocytic leukemia is the PML-RARA gene. Okay, so that's the fusion gene that leads to the abnormalities in in acute promyelocytic leukemia. So this slide right here shows you the molecular physiology of the RARA gene, which is the retinoic acid receptor alpha gene that's involved in acute promyelocytic leukemia. The which is right here, the RARA gene codes for a ligand-dependent transcription factor that binds DNA at the RARA promoter site that's called retinoic acid response elements. Okay, and it is involved in the differentiation of myeloid cells, basically. So the ligand for the RARA is retinoic acid. So you need to have retinoic acid for that. Okay, so RA is retinoic acid. And, you know, retinoic acid is an intracellular metabolite of vitamin A. So basically, in the absence of retinoic acid, RARA binds to nuclear core repressors to block transcription. But when RARA is present, RA actually binds to the RARA, and it causes the release of the core repressors and the binding of transcriptional activators to promote transcription. Okay, so RARA serves as a molecular switch to turn on and off the transcription of certain genes, but you need this retinoic acid in here in order to release those and then to turn on transcription. In PML, which is a result of, I'm sorry, not PML, APL, acute promyelocytic leukemia, is a result of translocation 1517. There's a balance reciprocal translocation between the PML gene. PML gene stands for promyelocytic leukemia, and and that gene is located on chromosome 15. And then there's a balanced translocation, reciprocal balanced translocation with the RARA gene. Okay, this is also known as the retinoic acid receptor alpha gene on chromosome 17. Okay, so those two pieces of chromosomes come off of chromosome 15 and 17, and they form its own little fusion gene. Okay, so the fusion PML-RARA leads to a block in differentiation at the promyelocytic stage. All right, so what happens is that because of this translocation, now you have this fusion gene, and now there's no release of this core repressors anymore. And so it blocks the transcription of target genes that are needed for myeloid differentiation. So the pathologic abnormality in APL is that there is a block in differentiation at the promyelocytic stage. That's why you see so many promyelocytes in this condition. Okay, so with the leukemias that have a recurrent genetic abnormality, it's actually it's not that it's nice, but it's good because we know what the deficiency is. Some of them, as long as you know that there's this translocation that is happening, you could basically do something about it, right? So it's been years now since these were discovered. So there's therapy now that can actually try to undo what these mutations are doing, right? So it's like we know the mechanism of acute promyelocytic leukemia. We know that, you know, that this fusion gene right here, it's stopping retinoic acid from working, right? It can release these core repressors so that transcription can occur, right? So what do we do? Because, you know, you have to find something that to try to help these people. And so there's a way to kind of reverse this, I would say. There is the more kind of like the standard therapy for people with acute promyelocytic leukemia. It's all trans retinoic acid. That's what it's called. It's also known as ATRA. So it's really cool the way that it works, because it's what Atra is trying to do is to like block the effect that this is doing, that this fusion gene is doing, right? So we give high doses of, what the oncologist will do is give high doses of all trans retinoic acid. So Atra binds to the RA component of the fusion gene, releasing the core repressors and allowing for transcription to occur. So Atra is basically just a lot of retinoic acid, a lot of retinol. So that's why it's called all trans retinoic acid. So it's a lot of it. So it's important to know APL to try to recognize it. Once you find out if this translocation is there, like translocation 1517, then that's enough. You can say, oh, translocation 1517 is present, see lots of promyelocytes, we're going to go ahead and go with the diagnosis of APL. And the reason why this is important is because APL could be dangerous. It's actually considered a medical emergency, and the promyelocytes actually have hypergranular activity. Hypercoagulant activity. So we know that we have the hypergranular form and the microgranular form. The microgranular form has really, really, really little tiny granules that are non-visible, but they have procoagulant activity. And so you know, these granules can activate the coagulation system and start to deplete coagulation factors, eventually form and cause DIC and thrombocytopenia in a patient. If this patient was found to have leukemia other than APL, but it was really APL, and if they're subjected to therapy like chemo, chemo can actually intensify this process, and it can release more granules from the APL cells. It can cause DIC and thrombocytopenia, and it can be very, very dangerous. When APL is suspected, that's considered to be a hematologic emergency. And so they would give them Atra in combination with chemo, at this point. But Atra would really try to revert the effect of the mutation, right? By kind of releasing these core repressors and allowing the differentiation of the cells to occur. We don't want lots of promyelocytes because of the potential that they have to activate the coagulation cascade. All right, so anyway, so this is kind of like a combination chemo and Atra for APL, but it's very important to identify it quickly. And then we have the category of acute leukemias of ambiguous lineage. So these are the ALALs, and they include leukemias in which there's no clear evidence of differentiation along a single cell lineage. They're also known as acute undifferentiated leukemias. And like I said before, we used to be very we used to rely a lot on the cytochemical stains and interpret them. Now flow molecular cytogenetics is more common, but the older techniques, the older classification schemes relied heavily on cytochemical stains, like the FAB used to stain the cells with these different types. So there was myeloperoxidase, MPO. That's an enzyme that is found in the primary granules of granulocytes, and lymphocytes don't have them. So they would try to see the lineage based on the reactions of the granules and the internal contents of the cells, of the white blood cells. There was Sudan Black B. That was another technique to differentiate AML from ALL. Sudan Black SBB stains cellular lipids, and the pattern similar to that as MPL. And then you would have the esterases, which would stain, which esterase reactions were used to differentiate myeloblasts and neutrophilic granulocytes from the cells of monocytic origin. And two substrates were used, the alpha-naphthoacetate and the alpha-naphtobutyrate. And so those are just some examples of what the stains would look like. But again, we used to classify these based on what these reactions were. So basically something like this. It was an ALL if it was variable for the last two stains, right? AML and POSBB, right? So that was really all we had. But now, obviously, the diagnosis is going a different direction. There's bone marrow analysis, there is cytogenetic analysis, and then immunophenotyping by flow. And so with some of the AMLs, it's still very important to take a look at the CD markers as well. Then you have cytogenetics and you have molecular. So cytogenetics is the study of the karyotyping, right? So it's the study of the chromosomes and what are the chromosomal abnormalities. Molecular is used in cases in which you can find additional genetic mutations. So if the translocation is known, okay, you could do molecular testing to look for those fusion pieces, right? So we know that translocation 922 leads to the fusion of BCR-ABL1 fusion gene. Those fusion genes can be found by doing molecular tests, especially RT-PCR. There's RT-PCR and quantitative RT-PCR. So RT-PCR would say, oh, yeah, mRNA transcripts are present. Here they are. But the quantitative RT-PCR can actually quantitate those. And that's important in terms of monitoring, because if you're going with therapy, right, when it's a type of leukemia like this, you want to actually quantitate those mRNA fusion transcripts, okay? Because then you want to say, oh, this patient can actually reach molecular remission. So when you don't see any more mRNA transcripts, there's molecular remission, right? There's basically different types of remission, but the one that you really want in leukemias that are like these are molecular remission, which means there are no more mRNA transcripts present, like this therapy is working, right? So there's qualitative RT-PCR, there's PCR, there's SNP-RAs, there's DNA sequencing, there's, many different techniques that you can use in molecular, but PCR is like the standard. And PCR is helpful in identifying mutations. So there are additional mutations that we want to identify in acute myeloid leukemias as well, like the FLT3 mutations, the NPM1 mutations, the CEBPA mutations, the MLL mutations. Those are very important for a prognosis for the patient and for kind of like the progression of this condition, right, for the patients. So these are the risk assessments. These are regularly updated as well by the congregations that, classify these leukemias. So you have AML, you have the AML patients with cytogenetic abnormalities. So the ones that have T translocation 1517, the ones that have translocation 821, inversion 16, those are kind of put in this favorable risk category. But on the other hand, you have the ones with deletion of 5q, deletion of 7, translocation 922. These put the patients in an unfavorable risk, right? So for AML people that have a normal karyotype, okay, for AML patients with a normal karyotype or intermediate risk cytogenetic abnormalities, okay, if they have these additional genetic mutations like the FLT3 ITD negative mutation plus the mutant PN1 plus a mutant IDH1 or IDH2, it will place them in a favorable risk category, okay? But if you have these, then they're in intermediate. If you have these, they're in unfavorable. So it really will lead you in different directions, right? So it's important to know the genetic abnormalities. It's important to know the mutations that are there so that we can figure out where the patient is going to be put. That is going to tell the physician, like, okay, this is going to be the course of treatment. This is going to be an aggressive treatment, or this is going to be let's just, start doing this first, and then we can figure out what to do next. Anyway, so with that said, what are the characteristic features of the peripheral blood smear in acute leukemia? And then what are the 3 most important tests that we have to do to identify and to diagnose and prognose the patient. What do you think? Anybody still there? What do we think? Anything? Any reminders? There's the three most important tests would be well, the characteristic features in a peripheral blood would be the blast, right? You see blast cells. And the three most important tests is a bone marrow analysis, cytogenetics, and molecular testing. That's very, very, very important in an acute myeloid. And so we go back to the case. We now see that this was a 7-year-old patient with a high white blood cell count, a low hemoglobin, a very low platelet count, and she was very tired, headaches, and then developed bruises, nosebleed, fever, ecchymosis. So there's bleeding there, a little bit of enlargement of the spleen, and also some hepatomegaly, right? So with the diff, we saw that they were 93% blast, so we know that's an acute condition, right? So what are the abnormals? Well, white cell hemoglobin platelets definitely abnormal. What are the identity of the cells? Blasts. Why does the patient have a fever? Well, because it goes hand in hand with what's going on with the patient, decrease in neutrophils, and also a decrease in platelets, right? And so these are some of the additional tests. The bone marrow had 100% cellularity, and 90% of it were blasts. So that's an acute leukemia. Now, do we know if it's myeloid or lymphoid? We can't tell unless we do a flow. So we saw that there was co-expression of CD19, 20, and 10, 22, CD79A, and a negative expression of CD34, 3, 5, 4, 8, and 7. So this really is telling me that the numbers of the CD markers are a little higher. They look like B cell, okay? And we have negative 4 CD34, which means it's not a stem cell. And CD 3, 5, 8, 4, 7, cytoplasmic immune globulin, surface immune globulin. Those are characteristics of T cells. So we're seeing that it's negative for T cells, but positive for B cells. So now I'm looking at a myeloid issue, at a leukemic issue with blasts, so an acute leukemia, and we're looking at some of the B cells now that are being implicated. And so when we did FISH, it gave us a positive for a fusion gene, the ETV6 RUNX1 fusion gene, and translocation 1221, but we had a normal karyotype. So basically what that means is no deletions, no additions of chromosomes or anything like that. And so with that said, the patient it falls under the category of B lymphoblastic leukemia lymphoma with translocation 1221, TEL, AML1, or the ETV6 RUNX1. These are both the same fusion gene. And the prognosis for this patient is pretty good, and there's a cure rate of 90%. All right. So just to get an idea of what that would look like if we were to start looking at some of the cases for leukemia. Are there any questions?